Good afternoon, everybody, and welcome to our second webinar in the series of 6 on lowering your cholesterol. The series is called Beyond the Numbers, and today's webinar is all about statins. Who, what, when, where, and why. Lessons that we've learned from each other. I wanted to first take a moment and give you some introductions to the organizations who are hosting this webinar series. We have Mended Hearts. Mended Hearts' mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. We also have joining us in this webinar series is the National Lipid Association, and their mission is to enhance the practical management in clinical medicine of lipids. And the foundation of the NLA's mission is to improve the welfare of patients and families affected by cholesterol and triglyceride problems. So the three organizations have come together to bring this lipid control webinar series to you all to really deep dive into the ways to deal and lower your cholesterol. Joining me today, my name is Andrea Baer. I am the Executive Director of Mended Hearts. And joining me is Mary Catherine Cheeley, who is a clinical pharmacist specialist in primary care from Grady Health System in Atlanta, Georgia. And also with us is Al Voss, who is a statin patient, and he is the treasurer and corporate secretary of Mended Hearts.
Thanks so much. So I know that you guys are all here because you want to learn about statins, but I want to take us back a little bit to elementary school and talk about the who, what, where, when, and why of statin therapy. So my name is Mary Catherine Cheeley. I'm a clinical pharmacist. So my specialty is not only primary care, but also advanced lipid disorders. I do work in Atlanta, Georgia, and I run our advanced lipid clinic at Grady Health System, which is about a once-a-week clinic. So the topics we're going to talk through today are, we'll go to the next one for me. Thanks. So who should receive a statin, and then who we're going to believe, what is a statin and what does it do, where I hurt if I have a problem, when I have a problem, so when that kind of occurs, and then why do we even take statins in the first place. But I want you to be aware, we are going to jump around, so we will not go in this order. But we will get started right now. So let's start off with who. I think that everyone on this webinar probably knows that it's a lot of people that should take statins, but I kind of want to break it down into 4 groups for you. So the first group that we're going to talk about is patients who have had heart disease, or ASCVD, which is our acronym way of saying atherosclerotic cardiovascular disease, which is our fancy medical terminology for heart attack, strokes, or peripheral artery disease. These are patients who have already had an event of a heart attack, stroke, or PAD, and so we want to reduce their risk of having another one. But there's 3 other groups. So the other group that you'll see to the right is familial hypercholesterolemia, which is a genetic condition of extremely high cholesterol, which does cause early events in life. With statin therapy, we have been able to save a lot of people from having those first events early in life, but we still want to reduce their risk. The 2 on the bottom are people who have not had ASCVD or not had heart disease events yet, but they are at high risk. The group on the left has diabetes, and the group on the right does not have diabetes. However, they do have an elevated 10-year risk, which we'll get a little bit more into those groups in the next webinar and some others down the line. But we're going to focus mainly on that first group, which is previous ASCVD. So what is a statin? At its core, a statin is a medication that lowers your bad cholesterol, or your LDL cholesterol. The 7 statins that you see listed on the bottom of this slide are the ones that are commercially available in the United States. And all of them have the same end result. They will all lower your bad cholesterol. So in my practice, we say that the L in LDL stands for lethal. And that means that that's the number we want as low as possible because it causes heart attacks and strokes. But what does a statin exactly do? So it lowers your cholesterol, but what does it do and how does it do that? You'll see there's a picture on the next slide at the bottom. So it does this, it lowers your risk of heart disease by 4 different mechanisms. The first one is it slows down your body from making extra cholesterol, actually within your liver itself. It increases the amount of cholesterol that your liver takes out of the blood, which is important because that then leads to a decrease in the size of the atherosclerotic plaque in your artery. So you'll see the picture on the right-hand side. You have one artery on the left, which is normal. It's beautiful, it's flowing great. And then you have another artery on the right-hand side, which is narrowed. You see the little yellow gunk that's in the side of it. That's called a plaque, and that is full of cholesterol. So what a statin does is it is taking the cholesterol out of your blood back to your liver so that it can be disposed of. When your blood cholesterol decreases, it actually pulls cholesterol out of that plaque as well and makes your plaque go smaller, kind of. With that decrease in your plaque size, you're less likely to have a heart attack or a stroke because your blood can flow better. More than that, though, your statins will come and stabilize any plaque that you already have. You can kind of think of it like a bandage that you're putting on top of that plaque. A plaque that ruptures causes a heart attack or a stroke. A plaque that is smaller and does not rupture is what we want. We know that we all over time will create some type of plaque in our arteries, but we want them to be nice, stable, skinny, small plaques so that they don't cause any problems. And the last thing that a statin does is pretty trendy. We all like to talk about inflammation these days, and they are anti-inflammatory, which is one of their mechanisms for reducing heart disease. But a statin's not the only thing that we need in order to reduce our risk. I call it the dream team. So there's 3 different parts of reducing your risk of heart disease. The first one is, or one of the 3 is definitely statin therapy. The other is a healthy diet, and the last is physical activity. We do have another webinar on July 16th that will talk about healthy diet, so I encourage you to tune back into that one. But today we're mainly going to focus on that statin piece, but I don't want you guys to think that that is the only way to reduce your risk of heart disease. So why take a statin? I mean, I can just eat right and exercise, and I should reduce my risk of a heart attack or stroke. That's true, you can, but taking a statin will actually lower your risk of having a first event. If you've already had an event, it can certainly lower risk of having a second event. But the things that I think are most important about statins that don't really get talked about a lot is that they are extremely safe and they are extremely well tolerated. And then I'm sure all of us remember from when we're children, it's because I said so. Your provider has done a lot of extra training and extra work to learn what is the safest, most effective way to lower your risk of heart disease. And because your provider told you to do it, you should probably do it. And this is one of the reasons why. So the cholesterol treatment trialist published a paper in 2010 looking at all of the different statin trials that we had seen to date, and they've actually updated it a couple of times since then. And they saw that even patients with a healthy lifestyle and a good diet are in that red bubble that says no statin. So they have a higher cholesterol and they have a higher risk of heart disease. As they add statin therapy, they move to that white bubble, which says statin. That reduces their cholesterol, but also reduces their risk of having another event. And then we went a step further and saw that the dose of your statin really does matter. The higher the dose of your statin that you can tolerate, the less your risk of heart disease will be. That all sounds great. Statins do good things, but I've heard some bad things too. We're going to be fair and balanced here, so we're going to talk about the good, the bad, and the ugly. But the first thing I want to ask you guys is, who do you believe? So we asked this exact question to about 1,500 patients who had reported having some kind of adverse effect to statins, and this is what we found. The group that's in the blue boxes are patients who took a statin, had a bad adverse event, and couldn't take them anymore. And the patients that are in the orange bars are the ones who took a statin, had an adverse effect, but then were able to continue on their therapy, be it a different therapy, a different dose. And you can see overwhelmingly that patients who got their information from a credible medical source, be it the internet or their medical doctor, nurse, or pharmacist, we're more likely to be able to stay on their statin therapy. So I really encourage you guys, if you're having any questions about your statins or any of your medicines, that you talk to your doctors about it, because that makes you more successful with your therapy. But what if I have a problem? It's not really when, it's more if that you have a problem. So remember, we talked about statins are extremely safe and extremely well tolerated. They are very, very rare to have an adverse effect from a statin. But if you do, it's important to talk to your provider. If your provider is at a loss of what to do, say maybe you've tried a statin or two, then you can certainly always ask for a referral to a lipidologist. So lipidologist is a fancy way to say cholesterol doctor. So there are several of us throughout the nation, and there is actually a registry on lipid.org for the National Lipid Association, which will tell you where you can find a lipidologist in your area. This is what we do. So we are specialists in cholesterol management. We pride ourselves in being able to get people on something that they can tolerate. So please reach out if you've had any issues with your statin therapy, or if you have any additional risk factors that your doctor just can't seem to wrap their head around. We are happy to talk to you about those. If you do have a problem, the most likely problem to have would be muscle aches, or what we call in the business myalgias. That's our fancy term. So where does that occur? It's large muscle groups. As you can see from our picture on the side, the largest muscle groups in the body are your thighs, as front and back of your thighs, as well as your buttocks, your upper chest, and upper back. Most commonly, it would be both sides of your thighs that would hurt more commonly, but it is both sides. So if you're just having muscle pain on one side, less likely to be your statin. If it's both sides, that makes us think a little bit more about it. Typically, you will start to hurt within the first month, and it does go away when the drug is stopped. So it's not something that lingers past when the drug is stopped. It generally takes about a week, maybe two at most, to completely clear out of your system. Your muscles will recover. It's not a long-term kind of issue. I heard that last week some people had some questions about coenzyme Q10, so I wanted to make sure that I address that here. Coenzyme Q10 is a naturally occurring, not really a vitamin, but kind of a vitamin in your body. It helps the mitochondria in your cells produce energy. What we do know about CoQ10 as a supplement is that being on a statin does cause a low circulating CoQ10 versus patients who are not taking a statin. But what we don't know is if supplementing with CoQ10 by taking a tablet or a liquid, if that actually gets inside the cell. So you can kind of think of it like a car and an engine. The engine is the mitochondria within your cell, which helps your car run or helps give energy to your cells. And we know that there's gasoline in the gas pump, but we don't know if that gasoline in the gas pump actually makes your engine run better, because we don't know if it can get into the car. So I hope that makes sense to say that coenzyme Q10 is likely safe. It does have a drug interaction with warfarin. You do need to make sure that if you're taking warfarin, you always talk to your pharmacist about any new medicines that you're taking, especially over-the-counter medications. But coenzyme Q10 doesn't have any kind of nasty side effects that we know about. It can be expensive. So if you're taking CoQ10 and you're not able to pay for your prescription medicines that do, we know, reduce your risk of having heart disease, then that's certainly something to talk to your doctor about. And the dose that is recommended if you choose to take CoQ10 is 200 milligrams at bedtime. So let's talk a little bit about that survey that I mentioned earlier, the Statin Adverse Treatment Experience Survey, or the STATE survey. Was a 4-year project. It was a collaboration between Amgen, the National Lipid Association, and Health Research Associates. We invited 43,000 patients, if you'll go to the next one, 43,000 patients to be included in an internet survey. Of those 43,000 patients, 21,000 patients had taken statins within the last 2 years, and 4,300 had experienced some type of side effects. So of patients who had taken statins in the last 2 years, only 20% of them had some type of statin-related adverse event, which is pretty rare. We limited it to patients who had had a statin-associated side effect within the past 6 months because we were going to ask them a lot of questions and we wanted to know exactly what their experience had been. Of those patients, the 1,500 patients, if you'll go to the next one, you'll see that they ranked their severity of their symptoms, one more, of severe or very severe. So the blue bars are patients that stopped their statin, and the gray bars are patients that are currently taking their statin. So let me remind you again, all patients in this study had some type of statin adverse event. Some of them were able to continue on some type of statin therapy, and that's the gray bar. And then there were some who gave up and were not able to tolerate anything, and that's the blue bar. And you can see the blue bar, excuse me, the ones that stopped their statin were more likely to report severe or very severe symptoms. So go to the next one for me, please. All is not lost if you have a symptom. It doesn't mean that we have completely lost all options. You can see in the next graph, you have patients who lowered their dose or switched to a different statin. And those patients who had some type of change in their therapy were more likely to continue on their statin therapy. In addition to that, on the next one, you'll see that there are other options. So 50% of patients, whether they stopped their statin or not, were willing to try another statin or a different therapy. The add-on therapies that we have include ezetimibe, which is Zetia, icosapent ethyl, which is Vascepa, or the PCSK9 inhibitors, of which you have alirocumab or Praluent, or evolocumab, which is Repatha. Those are in no particular order, it's just alphabetical, excuse me, but those are the options that we have for add-on therapies at this time. So I want to take my last few minutes that I have with you guys and tell you about the lessons that I've learned from my patients before we hear from Al and his experience. The number one thing that I've learned about my patients over the 10 years that I've been doing this is that they want to reduce their risk. They desperately don't want to have another event, and they don't want to have a first one in the first place. But they also don't want any annoying or hurtful side effects. Nobody likes to hurt. It's not worth it if we go through our day aching and groaning all day. But we can find something that works. When we work together, it may take us 5 or 6 or 7 tries in some attempts, but it certainly is something that we can come to some type of treatment for patients. I don't have a single person in my practice who we have given up on. Like I said, we may have to try 5 or 6 things, but there is always something that we can find to help reduce their risk of having heart disease. But honesty is the best policy. I, as your provider, am going to be honest with you, and I need you as the patient to be honest with me. Tell me about the symptoms that you're having. But more than that, tell me how you're actually taking the medicine. If you're not taking it, or if you only take it a couple of times a week because you're having a side effect, or just because you forget, I need to know that so that we can either create a better plan for how you can be successful with the medicine, or we can change it to something that you can tolerate so that you don't have to be miserable. But just like your mother taught you, honesty is always the best policy. So thanks for paying attention, and I can't wait to hear what Al has to say.
Thank you so much, Dr. Cheeley. That was great. And so, yes, now we're going to hear from Al Voss in the patient perspective. Al is a patient on a statin, and I'm going to let him tell you his story. So, Al, I'm going to turn it over to you.
Well, thank you. Thank you very much, Andrea, and thank you, Dr. Cheeley. This was very excellent and great information. Yes, I'm a patient. I'm a 67-year-old patient. I had my heart event and my heart surgery, I should say unexpected heart event and heart surgery 4 years ago next month. And right after that, I had a stroke. So it was a busy year in 16. What led me to the statin therapy? Well, it was my heart event. It was very simple. My doctor put me on a statin while I was in the hospital. So when I started statins, it was a joint decision between my doctor and me, and I tend to listen, so it was really his decision. Statins are tolerated well by most people, but they can have side effects. And so some side effects go away as your body adjusts to the medication, some don't. And I've had very, very few side effects, but I do have something like a cold symptom, a runny nose, and some dry coughing. But that's not only related to statins, that's also related to some of the other medications I take. So I don't know if those side effects will go away. Do those side effects affect my life? Not at all. I would rather lower my cholesterol and try to prevent another heart event than and put up with the runny nose or the cough. And again, the runny nose and the cough are just is minor. They're not all the time. So to me, it's not an issue. One of the questions I was asked is, where do I get my information about statins? And I do believe that patients need the pros and the cons explained to us in a way we can understand it. If I have really a very technical description of something, I'm probably not going to understand it as well. So I don't see my doctor every week. I don't see him every month. I can exchange emails, but I don't go there. So I get my information from two places primarily. One's from the internet, and I look at studies that are published and clinical results that are described, and I read them, and I do understand them, and it gives me a lot of information. And the second thing, because of Mended Hearts, I get to attend many meetings every year where doctors and clinicians and researchers discuss the latest studies and research, and it really helps me understand what's going on with statins, and I'm able to bring that back to other patients with all the information I gain. And the last question, why am I on a statin? Well, really quick, I had the heart event, and I fit a profile, which is my LD level was higher than 190. I'm between 40 and 75. I have type 2 diabetes, and I have a 10-year risk of having another heart attack or heart disease. And so I need to be on a statin, and everything that I read tells me I need to be on a statin, and I am. It is an occurrence that I take a pill every night, and I have done that for almost 4 years, and I will continue to do it. Next slide, please. So questions that I ask my doctor, and I don't ask anymore because it's been 4 years, but the big question was, how does it benefit me? What does a statin do to benefit me? And what do I expect from a statin? What's going to change? And another question was, how long am I going to be on a statin? So I use it as the why, what, and how routine. And I got the answers, and I knew why the statins I'm taking them and how they benefit me. I knew what to expect in side effects, and I realized that I'm going to be taking statins for the rest of my life, and that's okay with me. The next one's sharing with my doctor and discussing options. Absolutely. The next two questions after that, it's critical to have a honest, open conversation with your doctor or your physician's assistant. They don't know what's going on unless you tell them. And if you have any questions, I tell every patient I meet, write it down, because you tend to forget these questions when you feel better or you don't have an issue. Write a question down. Doctors and PAs will answer your questions, just like Dr. Cheeley did. So have a very open conversation. Share all the options you have with the doctor. Go through them. And it's a shared decision making. As I said earlier, the decision to start a statin was a doctor's decision. I could have said no. It was a shared decision between us, and I elected to follow his advice, and I don't regret it for the last 4 years. So thank you for letting me answer a few questions that were posed to me.
Thank you so much, Al. We really appreciate it. And hearing a patient perspective on the topic is really informative, especially when we're talking about something like a statin. So now I would like to move into our question and answer period. But before we do that, I just wanted to alert you all to the next session in the series is managing hyperlipidemia with a sense of urgency. And that is actually on Thursday this week at 2 p.m. on Eastern time. And so now I am going to open up the question box, and I know that we have a ton of questions, and I would love to start that off here. Hold on one second. I just got to open it. Yeah. Actually, I think I'm going to pass it to Jody to ask the questions because she has it up on her panel. She's my sidekick moderator today, but she does have the panel of questions open.
Hello. One second, we got to echo. Okay, we have a few questions today. One of them is two questions in one. Do statins affect your blood sugar and make someone diabetic? And do statins affect your memory?
Those are fantastic questions. I'll take the first one about diabetes. Yeah, so those are fantastic. And I'm glad somebody asked them because I didn't talk about it. But yes, so statins, it is true that statins can worsen glucose tolerance. Doesn't necessarily mean that they cause diabetes. We say that they, quote unquote, unmask diabetes. So it's patients who would have already tended towards having diabetes. It just gets you there a little bit faster. But the good news is that with that dream team that we have, if you lose just 5 pounds, your risk of developing diabetes from a statin goes to 0. So it's important that we all use all of our tools together. We follow that dream team of healthy diet and physical activity, and that will mitigate or decrease the risk of developing diabetes just because of a statin. So that's question one. Question two is about memory. So memory is a little bit difficult to study. I will tell you that there have been lots of clinical trials looking at statins and memory, and none of them show that statins worsen, we call it cognitive function or your memory. But again, it's really difficult to try to kind of get your arms around that because once you take a test so many times, you just remember the results. Or there's things like, well, do you forget your keys? Well, I'm in my 30s. I forget my keys, but you know, I'm not on a statin. So there's a lot of different ways to look at it. What I can tell you is from the provider side of it, if there is an adverse effect that a patient is concerned about or think that has started since they started their statin, it's worth kind of giving a trial off of the medicine, seeing if they go back to baseline. So when you're talking about memory, stop your statin for a couple of weeks, see if your memory comes back. If it does, then it might be related to the statin and we can try something else instead.
Okay, great. Thank you. And another question is there any evidence that CBD oil reduces cholesterol?
I am not aware of that. I know that there is another panelist coming, or another session coming up about, I think there's one about alternative therapies or something, and how to treat cholesterol. I'm going to punt that one to that one because I'm not aware of that one.
Okay, great. Another question is, do statins help you if you have elevated lipoprotein? The example is 126 milligrams over DL. I don't know what DL is.
Per deciliter, yeah. Yeah, so it's called lipoprotein little a, or LP little a is what we call it. And statins help reduce your risk if you have elevated LP little a or lipoprotein A, but they do not directly affect LP little a. So they will reduce your risk if you have an elevated LP little a level, but right now we don't have any therapies that do reduce your LP little a, and if they do, we don't really know if that reduces your risk, but we know that statins reduce your risk. So okay. Kind of, and yes. if that makes sense.
Okay, yes, it makes perfect sense. The next question is about the different types of statins. So it's do statins have some statins have a higher risk of developing side effects than others, and someone mentioned Amgen's Repatha.
Yeah, so gosh, these are great questions. I need you guys to teach all of my like residents and students to ask these really good questions. So man, they're good. Okay, yes, there's different types of statins. So we have two different classes. One of them is called our water-loving statins, or we call them hydrophilic statins. They are less likely to cause muscle side effects because they will stay in the blood space and not get into your tissues. We're getting real technical here. The other ones are called lipophilic or fat-loving statins. Those get more into your tissues, meaning your muscles, and are more likely to cause some kind of adverse event, but they are safer if you have kidney issues. So they both have their place in therapy. Again, most people will tolerate either one of them just fine, but that is one of our ways of getting patients to tolerate things. So say you're on one of those fat-loving statins and you had a muscle complaint, then that means that you can be switched to a water-loving statin and you might tolerate that one just fine. So those kind of simple things. As far as Repatha goes, so Repatha is not at all a statin. It is an injection medicine that you take either every 2 weeks or once a month, and it works in conjunction with a statin, so it's kind of a both and usually. If you're already on a statin and you need additional lowering, then you would take Repatha or alirocumab, which is Praluent. Either one of them, they work similarly. They're called PCSK9 inhibitors, but it is not a statin.
Okay, that is good to know about the different kinds, because we get a lot of questions about that, and some people are taking one and then they switch and they have fewer side effects, and so we've noticed that a lot at Mended Hearts. Another person was asking about the leg cramps and was talking about switching statins due to the leg cramps, and so I guess could you speak to that? And Al, could you speak as a patient? Did you have any experience with leg cramps, and what did you do about it?
Al,
go ahead, Dr. Cheeley. No, go ahead, please, and I'll follow up.
Sure. So leg cramps are actually the most common adverse event that I see in my clinic specifically. In the studies and in the literature, you read mostly about muscle pains more than cramps, but our patients tend to describe them as muscle cramps or leg cramps more often. We do have really good success with switching people from those fat-loving statins to the water-loving statins. But the key really is to go off of the statin, what we call wash out, meaning go back to baseline. So go back to where you don't hurt anymore. And then at that point, we reintroduce the statin, either at the same dose or a lower dose or a different statin. But we want to make sure that you do go back to baseline, because if you don't go back to baseline, then that means that it might be outside of the statin. Because remember, once the statin goes away, the muscle cramp should go away. There are lots of other reasons that people would cramp as well, but we want to make sure that we're trying to tease out, is it something going on with just your body, or is it the statin interacting with your body? But yeah, we have really good success with switching people to the different types of statin.
Well, thank you for that information. To answer your question, Jody, I started what I call cramps in the middle of the night, and it doesn't matter whether I have a lot of water that day or not, but I start them in the middle of the night. They don't last long, but I've had them all in my legs and in my hands, where in my finger, not necessarily in my fingers, but in the palm of my hand, where seems like the really cramping of the bones now. And I've written my doctor about it, but it's a nuisance. I call them Charlie horses, but they're not anywhere as bad as a Charlie horse. So I would agree that they're muscle pains, but I think everybody and all my friends call them muscle cramps.
Okay, thank you so much. And some of our patients have been writing in about the non-statins, and one of them just heard about, I think it's a new therapy. It's a bempedoic acid. Have you heard of that,
Yeah.
Dr. Cheeley?
Yeah, so bempedoic acid was just FDA approved. It is also not statin, but it does work in conjunction with a statin. So it's a different pathway. We don't really have any kind of real world evidence on it because it was just FDA approved. It's not really been out in regular consumption yet, but the studies look good. It looks like it'll give us probably an additional 20-ish% reduction, which is really helpful, especially because it's a tablet, it's not an injection. And so we think that we can kind of put a couple of different things together and get a really significant reduction in cholesterol in addition to what a statin will give you. But it's important to note, though, that all of these add-on therapies are FDA approved or approved by the Food and Drug Administration for addition to statin therapy. So none of these are really approved as standalone therapies. We don't have a lot of data on how they reduce your risk on their own. Every study that has been done on the backbone of statin. So it's important that we try to exhaust all of our statin resources and all of the ways to get people to tolerate a statin, and then we start putting these other things on top of it.
Okay, great. Yeah, we have been hearing a lot from our patients about some of these new therapies, and like you said, they were added in addition to the statins. So that's great. We had a couple questions that are very similar about do statins damage organs like the kidney and liver? And one of them related is raising creatine levels.
Yeah, so golly, you guys are great. It's like you went to medical school or pharmacy school or something. Okay. I almost wish that I
had patients at Mended Hearts.
Right. This is great. I wish I had a whiteboard and you could like see me draw all of these things, but alas, you cannot. So I will explain them to you. So statins, like I mentioned, are extremely safe. They have not been shown to damage any organs. However, damaged organs can affect statins. So it's kind of an if-then. There used to be, when statins first came out, the FDA recommended that you check liver enzymes because they thought, oh my goodness, they work on the liver, they're going to make your liver work harder. But that's been completely debunked, and that is not the case. So as long as you do not have decompensated cirrhosis, meaning really bad liver failure where you're in and out of the hospital because your liver is failing, statins are safe as far as livers are concerned. So that's great news. As far as kidneys are concerned, they're safe all the time, with the exception of if you have reduced renal function, which is that serum creatinine that someone is mentioning. If you have an elevated creatinine, then we would prefer those fat-loving statins instead of water-loving statins. So one of the examples of a fat-loving statin is atorvastatin or Lipitor. That is our safer statin in patients who have kidney disease because we know that it will not, it's not excreted by the kidneys, so its levels will not build up like its water-loving pair, which is rosuvastatin or Crestor. The other thing is when you progress to dialysis, if you have not been on a statin previously, so say you somehow made it all the way to dialysis and not having been put on a statin, we wouldn't necessarily put you on one. There's no data that's showing that once you have progressed to dialysis, that putting you on a statin will reduce your risk of heart disease if you've not been on one previously. Now, if you've already been on one, you're good to go. We need to make sure it's a fat-loving statin. But yeah, I hope that answered it. Statins don't really cause any end organ damage.
Great. Well, that is great to hear, for sure. Someone asked, does plaque accumulate on the heart valves as well?
Oh my goodness, you got seriously. Okay. Yes, kind of, and sometimes. So in patients who have an elevated Lp(a) or that lipoprotein A, it can cause something called aortic stenosis, which is the aortic valve in the heart. It can get plaque on it, which makes it harder for it to open and close. But that's not a direct That's not directly because of high cholesterol. It's because of high Lp(a), which is a type of cholesterol. So not everyone will have that. That's more of a genetic thing.
Okay, great. So that's good to know, because that's always nerve-wracking. You don't want your valves dysfunctional as well, you know.
Absolutely. Right.
Someone asked, how important is the LDL to HDL ratio?
That's a great question. And I'll come back at it from a different way. So LDL, like I mentioned, is the lethal cholesterol, but what is compromised of or what makes up the entire LDL cholesterol is something called non-HDL cholesterol. So it is a measurement of your total cholesterol minus your HDL cholesterol, which H means healthy. That's the cholesterol that goes around and eats up all the bad stuff and kind of acts like a vacuum to take it out of your blood. So we really follow your non-HDL cholesterol. That is your total risk. It's all the bad particles put into one. So back in the olden days, we talked mainly about LDL because that's the one that we knew about first. But now we've learned about Lp(a) and ApoB and all of these other really bad particles. But the easiest way to get at that is your non-HDL. So the ratio is not exactly as important as that total non-HDL number. But again, there's another webinar coming up. I think probably the next webinar we'll talk about that, and then maybe 4 or 6, they will probably go into that a little bit more.
Okay, great. Yeah, and we're looking forward definitely to hearing more about that. So a lot of people are asking about the time of day you take your medicine and taking it with other medicines. Could you address that some more? I know you touched on that.
Yeah, I would love to. That's my heart as a pharmacist, is how to take medicines appropriately. So yes, I've heard the old adage, and when I went to pharmacy school, they told you have to take your statin at night. The reason that we recommend, or it was recommended, that statins be taken at night is because your body makes the most amount of cholesterol while you're sleeping, which means if we want to have the biggest effect on your cholesterol, then we want to take it at nighttime, because what you probably don't know is that statins really only work for about 6 to 12 hours. They don't work all day. They really work for just a shortened amount of time. But then we started to look into this a little bit more and realized people don't remember to take their medicines at nighttime. They remember to take them in the morning. So they did some studies about when is the best time to take a statin, and it was found that if you take it at nighttime, you have about a 2% additional reduction in your LDL cholesterol. So as clinicians, we said, well, medicines don't work when they're left in the bottle. You have to actually take it for it to be effective. So I'll just throw that 2% out the window. And if you want to take it in the morning, you take it in the morning. If you want to take it at night, you take it at night. Just make sure you take it at the same time every day. So that's the first part of it, is I don't care when you take your statin, as long as you take it. The second part of that question is drug interactions and taking it with other medicines. It is perfectly fine to take it with other medicines. So statins don't really have a ton of drug interactions. They interact with some HIV medicines or some anti-rejection medicines. But all in all, they're very safe. So make sure, again, you talk to your pharmacist before you start anything new. And then other medicines can affect the statin. So, or, taking things together. So if you're on a medicine called cholestyramine, which is a powder, or cholestyramine, which is a tablet, if you take thyroid medicine, those other medicines can be affected by the statin, but the statin itself will not be affected. So it's always important to talk to your pharmacist when you start adding new medicines to your regimen.
Okay, great. And we have a fun question too. A lot of supplements there that say they're more effective than statins. Is that really true, or is it just people trying to sell me snake oil?
It's lies. It's all lies. That's a great question. So there are, first of all, thank you, because I feel like there's a lot of people that don't want to ask questions about supplements. So thank you to whoever read that in. Supplements are, in pharmacy school, we learn that any supplement can be marketed. I could make it in my bathtub and put a label on it and sell it to you. So you don't know that what's in there is actually, number one, in there, or number two, safe. Nothing is going to be as effective as a statin. So at the highest doses that we have, your statins can reduce your LDL cholesterol by about 60%, which is huge. The most common over-the-counter ones that you could think of, which would be garlic or red yeast rice or those kind of things, it's about 15% reduction. Even if you put all of those together and you take a fistful of supplements, they still won't get you those additional effects that we talked about, like anti-inflammatory or the reduction of the plaque in the side or stabilization of plaque. That is unique just to statins. So while your number may look better if you're, eating fiber and Benecol and red yeast rice and garlic and all these other things, you will not get that added benefit of the plaque stabilization or reduction of the plaque in the actual vessel wall.
Okay, well, that's good to know.
So they're just trying to sell you snake oil.
Right. Because I know a lot of people who are going around smelling like garlic, and it's good to know that they could just statin and avoid that odor. So anyway, we have several more questions about side effects. So in the side effects, people are asking about are heartburn, raising blood pressure, and chest pain and tightness. So could you speak to those?
I would love to. I'll go back to what I said originally and kind of talk about how if there's a side effect that you're worried about, as long as you're, not right after your stroke or right after your heart attack, it may be worth it for you to talk to your doctor and try to see if maybe you can just trial off of the medicine for a little while and see if it gets better. As far as heartburn is concerned, I do have some patients complain of heartburn, and we realize it's because they're taking their medicine at night and then they lay down to go to sleep. And that causes a little bit of what we call esophagitis, or kind of that heartburn feeling in your esophagus. So they take it in the morning and they're doing just fine. What were the other ones? Chest pain and chest tightness. Yeah, chest pain and chest tightness, I would certainly talk to your doctor about those because it could be multifactorial. Statins have not been shown to cause any kind of true heart pain. That may be just a progression of your heart disease. You certainly need to talk to your doctor about that and be honest and talk about. So just like Al mentioned, I love his recommendation of writing things down. So be really in tune with that and think about when it happens, what makes it better, what makes it worse, when does it happen? Does it happen at one particular time of day, or is it after you walk up the driveway to check your mail? Those are things that your doctor is going to need to know, but you definitely need to talk to your doctor about any kind of chest pain that you're having. As if it's muscle pain, so say it's muscles in your pectoralis muscles or your upper chest muscles, that could be your statin. And again, those you also need to talk to your doctor about.
So following up on the muscle pain, we've had several questions. Will the muscle pain go away, or does it?
Yes, it will.
Okay.
It does. So when you stop the medicine, it should take about a week or two and you'll go back to baseline. Again, if you're having these crampings or if you're having muscle pains and they don't go away, it's probably not because of your statin. And in that case, me as the provider, I'm going to say, well, then we should start your statin back. We need to figure out what's going on. But if it's not your statin causing the problem, we need to reduce your risk of heart disease. We can certainly work on this muscle pain another way, but if it did not go away when you stopped the statin, then it's probably not the statin. It does take about a week or two for it to go away. So remember, it takes a week for the drug to get out of your body, and then it probably takes another week for your muscles to go back to normal. But if it truly is the medicine, it will go away.
Okay. We have a question about lifestyle versus heart risk. And the question is, how do you convince patients to try a statin who want to focus only on lifestyle when they are high risk?
Ooh, that's where my powers of persuasion come in. So my doctor that I work with, the physician that I work with, always tells everyone that I'm one of the most persuasive people that he's ever met. And it's true, I am. So I think it really depends on the patient. And you have to kind of figure out the why of the patient. So not only, why do you not want to have another event, but but why are you not willing to take a statin? What have you heard, or what are you scared of? Because then there's so much evidence and so much that we know about statins, and they really are so safe. They're one of the safest medicines on the market. I always tell my patients, the aspirin that you're taking is probably more dangerous than the statin that you're taking. So and you're certainly willing to take the aspirin. So we need to kind of break down those barriers. And it may not be that today I can convince you to take a statin, or maybe we start at once a week or twice a week. And because people are really afraid of the side effects, they've heard it on the news, or my best friend's brother had this happen. So I definitely try to go back to what is the hang up for the patient, rather than just try to beat them over the head with the evidence. Because if I'm not speaking to the challenges that you are facing, then I'm never going to get anywhere.
Okay. I just wondered, Al, did you have anything to add, like what convinces you as a patient to try something while you're concerned about your quality of life versus your risk?
If I read something or hear something on a new study, or it gives me information, or like picking up information from Dr. Cheeley today, if I gather new information, I write it down. And now, because of the virtual doctor's visits, I actually just send an email, and I get my doctor's opinion that I should go on it, or should try this, or I should not try that. And I'll have reasons. You should try this because, or you shouldn't try this because they have all my electronic medical records from years back, and they can go down and, they pretty well have my history. So that's what makes me write the question and submit it. And if I have a doctor's visit in the near future, a month out or 2 months out, I might save those questions to the end. But COVID has really made everything change, from businesses to doctor's visits, and now it's just really great to get an email answered without having to go to the office to ask that question.
Okay, well, it's certainly important to ask patients when you're dealing with quality of life and risk issues. We only have time for one more question, so and we have that question, and there are a lot more questions. So what we are going to do, we're going to save these questions and make sure they get answered for you. But and we will have a recording of this as well for you guys to listen to later. But so the last question is there any benefit to starting a statin at a younger age to prevent plaque buildup?
Oh, that's a fantastic question. And I think it's a perfect teaser for the next webinar. I do have opinions on that, but the data is a little bit, it's developing, let's put it that way. So I'm going to actually ask the next presenter to talk through that. But we know from those first few groups, the 4 groups that I talked about, that starting a statin when you are high risk but have not had an event yet, that is really important. And again, that's a discussion that you can have with your primary care doctor, is when should I start a statin? But I actually think that's a perfect segue into the next webinar. So thank you to whoever asked that question.